Welcome to Compassionate Conversations. The goal of our podcast is to explore topics related to serious illness. Ancora Compassionate Care exists to be a supportive presence for life's journey. We can provide care and support wherever a patient may be on their journey with a serious illness. Ancora Compassionate Care began as Hospice of Rockingham County in 1987. While our name changed in late 2023, we are still the local provider the community has always known. We'll always be there because we've always been here.
Welcome to this edition of Compassionate Conversations. My name is Flavel Collins, and I am Director of Marketing for Ancora Compassionate Care, and I'm sitting in today for Lynn Flanagan, who is our regular host of the podcast. Joining me today is Rhonda Lucas, who is one of our nurse practitioners in our Serious Illness Care program, and Rhonda serves as the team leader for Serious Illness Care. So welcome, Rhonda.
Thanks, glad to be here.
In one of our past episodes, we did a broad overview of our Serious Illness Care program and all that goes into that. But today we want to do a deeper dive, if you will, into one of the specific illnesses that we see on a fairly regular basis within the Serious Illness Care program, and that is chronic obstructive pulmonary disease, or as we more commonly refer to it, COPD. Rhonda, tell us a little more about COPD from a serious illness care perspective.
Well, here in North Carolina, we have a high number of folks who have been smokers or who have had exposure in their environment, like a work environment, to cotton mills for fibers over the years. And as a result of that, and for no reason that we know of, there are folks with COPD. Commonly called emphysema or bronchitis. They're two different kinds, and so they're treated a little bit differently, but they are both obstructive, and that's where the COPD comes from. Asthma, a lot of people will call asthma a COPD, but really it's not. It's more of a restrictive disease where the airways actually close. In COPD, the air gets trapped, and these little sacs that we have in our lungs, as we breathe in, the air comes in, and the exchange of oxygen and CO2 takes place on the membranes of those little bubbles, I call them, or sacs. And what happens in COPD is that they fill up, but the ability to exhale and get all that out is very much reduced depending on the stage of COPD. So we're seeing a lot of that in our serious illness program. People from their 40s up to the 90s, but typically 60s, 70s, and 80s.
Okay. So what would you expect a typical COPD patient to look like from your perspective?
Well, the textbook picture, literally, that when we learn about COPD as providers, is that a lot of times, depending on which kind they are, whether they have bronchitis or whether they have emphysema, will have different traits, physical traits actually. So, like an emphysema patient typically has a barrel-shaped chest where this air has gotten trapped, and they can have problems and having to go to the hospital with pneumothorax, which is when the lung collapses because those little pockets will actually burst and open in severe cases. The bronchitis COPD patients typically are those who have bronchitis frequently. They're coughing up something almost all the time. They have all this excessive mucus production, and so they will have, a lot of times their nails will be they'll go to the end of their fingers and they'll curve over the end of their fingers. But more than anything, they're very short of breath with exertion. And I'm not saying like running a mile either. I'm saying like going to the bathroom is exertion for them. Right. And they become oxygen dependent at some point usually.
Yeah, I would imagine a lot of those daily activities that we all take for granted become just monumental.
Yes,
when
and
you're short
so
of breath.
frustrating for the folks because they're used to going out and working in the yard, or they're used to, doing their own laundry and their own dishes. I have a lady that talks about, she says, I'm just so frustrated. I have to sit down at least 3 times while I'm fixing breakfast. Or sit at the stove and stir the eggs or the grits or whatever she's having. And she says, I want to still do it, but I have to take my, I have to rest in between. And she just is very frustrated, as so many of them are, which can cause depression too, because they're depressed about their state. But
understandably so. So for a COPD patient, how would our serious illness care be of support to them?
Well, they already have a primary care physician or provider, and some primary care providers actually treat the patient's COPD themselves and manage it. A lot of our folks now, though, go to a pulmonary specialist, and I always recommend that. It's become such a specialty, and the medications now that are available to those folks in inhaler form usually are getting complicated. They're not just one medicine in that inhaler anymore. They are 2 or 3, and you see them advertised on TV, and they hit the COPD or attack it from different ways. They don't all do the same thing. One helps open up the airways, one helps reduce the inflammation in the airways, and then the other ones can actually help with the exchange of air and help reduce the burden, the lung burden and the muscle burden in the chest, because they can get really burdensome and start, cause pain, tiredness, fatigue, all that. And so we often encourage them to go to a pulmonary specialist. If they don't want to, or they have difficulty getting out, we certainly understand. And we'll assist the primary care physician, because that's what we do. We don't go in and try to change anything. We work with the primary care and or specialist to help them be as comfortable as they can. COPD is not curable, but it is treatable. And there's some things a patient can do to help them live a longer and better life. If they're still a smoker, we understand that if you've been smoking for 50 or 60 years, sometimes talking to them is just not, it's not going to work. They're not willing to stop, and we get that. But we also tell them that you're going to have more frequent infections, or what we call exacerbations, which means they're having a bad flare-up. A lot of times ending up in the hospital, and nobody really wants to go to the hospital unless they have to.
Right.
And so we try to keep them out, and one of the ways is to be very diligent about their inhalers or their oxygen and or medication therapy. Stay in tune with their doctors, do what the doctor says, and take the frequent rest periods. But we work with their doctors. We don't come in and try to change anything. Now, sometimes they're in between doctors or specialists, or maybe they haven't been to that specialist. They used to go, I went years ago, and we didn't see eye to eye, or it just cost too much, so I stopped going. And the primary just continued on with that therapy. But there's so many new therapies out there now that, especially if someone is not at the end of life, I feel like they need to go to a specialist, whoever is on. That's all they do. So
Right.
they know the newest and the best in treatment.
So you talked about the little lady that it is very much a chore, if you will, to just fix breakfast. When you go in and see patients, or they come to the clinic to see you, what are some tips and some suggestions that you offer them to help them with just activities of daily living and help them live life to the fullest?
Well, the first thing we look at is their energy level and their safety when it comes to, because With COPD, sometimes their oxygen level can drop. And with a dropped oxygen level, if the brain's not getting enough, they may not be safe enough to be cooking. But if they are, and a lot of them are, then the second thing I think about with them before I start talking to them is, are they on oxygen? Now, I have a gas cooktop. I mean, you definitely don't want to have a gas cooktop.
Not a good combination.
And be using that with oxygen. So if she can do without her oxygen, or he, then he can come and cook. And, you know, we try to look at ways where, as much as possible, they stay as independent as possible. Because an independent person, 9 times out of 10, is the happiest and with their life and the best quality of life. But we can talk about microwaves. You know, you can scramble an egg in a microwave nowadays. It may not be as good as cooking it behind bacon in a frying pan, but it's still good. And ways to work around, just like with anything. I don't want to call it a handicap, but it's just you have to do things differently sometime according to your condition. Oxygen tubing alone is a safety hazard. If they have 40 feet of tubing, can you imagine? I have one lady, every time I almost trip when I go behind her when she lets me in the front door at her visits. And but you have somebody, and they have a dog or they have a cat, especially dogs, the little ones who like to come to the door and bark at you and welcome you in. And then you've got all the oxygen tubing, and I'm so afraid people are going to stumble and fall. There you go. That would be another something wrong with them, and they'd be even more dependent. So we talk about just simple things. Keeping things near at hand. Most folks with COPD who don't get up and do a lot for themselves have their own, what I call a nest. We may even have our own at home. Around our recliner or whatever, you have your little table. Most of these folks will have a table on each side, and they have things like their breathing treatment machine that they inhale every 4 to 6, 12 hours. They may have that over there. They may have their medicines over here. Somebody keeps them something to drink, or a snack or whatever close by. The other thing is, a lot of people don't understand when it comes to nutrition is that COPD and the struggle of breathing burns calories on its own. And so a lot of these folks are very thin. You may see somebody whose chest is normal size or even barreled out, but their legs and their arms are teeny-tiny. And a lot of times it's muscle mass loss because they're not able to do what they used to do, or they're not eating well, or what calories they are intaking, or have as an intake, they're being spent just on breathing alone. We have no clue, those of us who breathe well, how much calories that burns. And although a lot of us would like to lose a few, pounds of calories, that's not the way to do it. And so we have to tell those folks to stay, have supplements. And this is getting a little bit in the weeds, but just a lot of people don't know this. Starches, carbohydrates make this worse. They make the CO2 that's retained in the body worse. So the more they stay away from carbohydrates, the better their breathing will actually be. So just, and it may be things they've read, but they've forgotten, or their doctor or a provider has told them and they've forgotten, or even their home health nurse at one point told them, or their physical therapist. But we come in and try to remind, and you may have to tell people, over and over, because it's a lot to take in.
Sure. And especially if it's a newer diagnosis, I'm sure.
Right. And those commercials, I do love the commercials where they actually lay down the cigarettes and they decide they're going to start a new life. Now, the COPD may get a little better, more manageable. It's not going away. But at the same time, they are going to have a better quality of life probably, because they're not going to be as sick, infection-wise. But for those who insist on continuing that, or maybe it's to have 6 dogs in the house and the dander is probably not helping, or dust or whatever. We go into their homes. We're in their house, their space, so we can make suggestions. I do make the suggestion often about putting a straight back chair or a stool in intricate places, like if they've got a long hall and it's hard for them to get down to the bathroom without sitting down. A lot of them will have those rollator walkers, and they can turn around and sit on it, but they're not really safe for doing that. That really should only be done in emergencies. So I tell them to get a straight back chair that they have from their dining room table and put it midway, or in their kitchen, a stool maybe, something that they're not going to fall off of, but yet they can sit down
Got
and
something
that's
to
high enough
plop
that
down
you
on.
right, so that you can be at the countertop and you can prepare salad, or you could even cook if you don't have oxygen on. So there's a lot of little, like you say, tricks and tips to help people manage and have a fuller life. It's not a death sentence anymore,
Right.
and thank goodness for that. And then depending on their age and what's causing that, a lot of times getting rid of environmental factors can really help them live a lot longer life, and maybe even get off oxygen. These folks aren't on oxygen until their oxygen saturation in their blood is less than 90%. So even though they may look short of breath and feel short of breath, that doesn't mean their oxygen's low.
Right.
It may mean that their CO2 is high.
Right.
And but I love that teaching part, because it's amazing how much somebody's illness can be controlled by just knowing.
Sure.
The knowledge is very much a power.
Sure. And to me, that's one of the beautiful things about serious illness care is you have more opportunity to teach. And if you need to go over something 6 visits in a row, you have that opportunity.
That's right. That's right.
So it's a wonderful thing to be able to work with our patients on a close basis like that.
And if I was working in a practice, I probably would not have enough time to talk. It would be up to a nurse, which would be fine. Or now that we have case management nurses out of some of these offices that actually do home visits, it depends. But we, Catherine and I really enjoy doing that teaching piece and having the time to do it. And you have to kind of massage it and get the right kind of teaching and the right approach for each person, and how they learn. Some people want something in writing, some people don't. They do more by, and if I've got a man, I usually, and I know that it depends on what they used to do. I may, talk about the lungs or the heart or another organ, like something they've worked with in the past. I think that's important too, to kind of get them to understand the attachment.
Right.
And the similarities, I should say.
Right. And how nice that you all have the time to develop relationships that the learning style.
Because you can't tell them everything in one visit.
You can't, because you'll do nothing but overwhelm them, and then they can't hear anything.
That's correct. That's very much right.
So that is a great aspect of our serious illness care program, is the teaching.
And not being judgmental. I have several patients who don't want to go to a lung doctor because they have in the past been not felt helped, but felt fussed at.
Right.
And I tell them, I said, I get it. You're 85 years old, and they'll say, the damage has been done. And so what's it going to, and I'll say, well, it's all up to you. You're grown, and you can direct this, but I have to tell you what can help and what can hurt, and then you make the decision. Right. And they love that. They love being given that autonomy and not being talked down to, but being a partner with them.
Sure. Well, I think all of us like to have the ability to make our own decisions.
And I'm glad that healthcare is now goes in that direction.
Right.
It hasn't always, and we know that. It was more driven by the physician, and that's fine. I mean, it's not like, it's just a different model.
It is.
Than nursing.
It absolutely is. Well, thank you for sharing a lot of information on COPD and some things that folks can think about doing that may make it easier for them to live with the disease. As you said, it's not a death sentence, and there's still a lot of living left to do.
There is, and I was looking at the stats, and I'm not a true numbers person, but there are states who have more incidents of COPD than we do, but we are among those of the higher. And we were a tobacco state for years and years and years, and you'll see that the worst is in West Virginia, Kentucky, Virginia, North Carolina, so, and that's probably has a lot to do with it. But as we learn more, we share that with our patients. And in serious illness, thank goodness we have that time and we enjoy doing it. And I appreciate you having me on.
Glad you could be with us. Thank you for joining us for this episode of Compassionate Conversations. If you would like more information about any of the services that Ancora Compassionate Care offers, please call our office at 336-427-9022, or you can visit our website at www.ancoracc.org. If you ever have a topic that you would like to have us explore on Compassionate Conversations, please feel free to call us, or you can email us at info@ancoracc.org.